Hey guys, welcome back to our channel. If you are new here, do know that we post exciting new concepts every week. So subscribe to our channel, the link of which is given below in the description. So today we'll be discussing mainly inflammatory bowel disease. But before we go with inflammatory bowel disease, we'll have a short word about bowel wall enhancement patterns. This helps us to come across differential diagnosis when we see bowel wall enhancement and thickening. So there are basically five patterns of bowel wall enhancement. They are white, gray, water halo, fat halo, and finally black. So we shall see each one and study their description, differential diagnosis, and the way they appear on CT. Now, an important disclaimer before we go ahead with this is interpret these findings only when a good CT enterography study has been performed. By good CT enterography meaning the patient's bowel are distended with either oral or neutral contrast. This depends upon the institute, the protocol. In our institute, we frequently perform neutral oral contrast, meaning water mixed with peg leg. Some institutes also prefer mannitol or peg leg, and that also works as a good bowel distension agent. Coming on to the first pattern of bowel wall enhancement, that is white. The way we pick up white pattern of enhancement is you have to look at the venous structure, that is either the IVC or the common iliac veins, and compare the enhancement pattern of the IVC or the common iliac veins with that of the thickened bowel. Now, the differential diagnosis for this is shock bowel, which is most frequently seen, and IBD, that is in the active stage. Let us see some images. In the first image, you can see that there is jejunal wall thickening that is showing mucosal hyperenhancement. Now, this enhancement is similar to that of the inferior vena cava. Now, you can also see that the inferior vena cava is collapsed less than 3 mm in AP diameter. This is a classic case of shock bowel that is seen in hypoperfusion, or also commonly seen when patient loses a lot of blood due to trauma. Another case of shock bowel, we can see that the IVC is chinked. Here, this is at the level of aortic bifurcation. You can see here that there is bowel wall enhancement which resembles that of the inferior vena cava. There is also ascites. This is a component of CT hypoperfusion complex which is very frequently seen in shock bowel. Coming on to the next example, we can see here that there is thickened bowel with enhancement. This similars that of the inferior vena cava. Now also here you can see that the vasa recta are prominent. So this was a case of inflammatory bowel disease. Why these vasa recta are prominent, we shall see in just a short while. After finishing white pattern of enhancement, let us move ahead with grey pattern of enhancement. Now this is described when the bowel wall enhancement is similar to that of the enhanced skeletal muscle. Commonly we use the psoas, but if that is not available in the section, you can use external oblique, internal oblique or latissimus dorsi muscles for your comparison as well. Now this is considered as the most non-specific type of bowel wall enhancement. It can be seen in both benign, inflammatory as well as malignant type of bowel wall thickening or strictures. Now let's see an example. You can see here that there is bowel wall thickening involving the cecum ileocecal junction, as I have highlighted here by the red arrows. This mirrors that of bilateral psoas muscles, so the pattern is similar. This was a case of carcinoma cecum with hepatic metastasis. So you can see that this gray pattern does not differentiate well between benign and malignant conditions. Coming on to the next pattern of enhancement, that is white halo type. This is described as symmetric concentric 2 to 3 layers of thickened bowel wall that is stratified with water attenuation in between the layers. This is classically seen in inflammatory bowel disease, Crohn's and ulcerative colitis alike, infectious disease and radiation enteritis. Now all these diseases in their active stage demonstrate this type of enhancement. Now let us see some examples of water halo sign. Here, this was a case of ulcerative colitis. You can see here that the descending colon and the transverse colon are thickened. The mucosa shows hyper enhancement as I've circled here. The serosal layer shows hyper enhancement. In between the two layers, there is water attenuation. So this is the water halo sign. A similar appearance is seen here in the transverse colon. This is another patient. Now look at the serosa. It is showing hyperenhancement. Now next come to the, sorry, this was the mucosa. Next come to the serosa. This is also showing hyperenhancement. In between these two, mucosa and the serosa, there is water attenuation. So this is water halo sign, and this was a patient of radiation enteritis. Coming next to the fat halo sign. This is a three-layered target sign appearance similar to that of the water halo sign, but it shows fatty attenuation in between. This is again seen in the same diseases that we saw in the water halo sign, meaning inflammatory bowel disease, infective, radiation enteritis, but important feature is it is seen in the chronic phase of these diseases. Now let's see some examples of these. In the first example, you can see the same patient that I have demonstrated in the water halo sign underwent treatment with steroids azathioprine and now has come with water halo sign. The mucosa shows hyperenhancement, the serosa shows hyperenhancement, but in between the two layers there is fat. The same in the transverse colon. So the same patient after treatment is showing fat halo sign, meaning he has gone to remission or the chronic phase of inflammatory bowel disease. This was a case of ulcerative colitis. Now the same patient of radiation necrosis after treatment is showing fat halo sign. You can see that the mucosa and the serosa are hyperenhancing with the in-between layer showing fatty attenuation. Now coming to the last pattern of bowel enhancement, that is black. This is classically seen in pneumatosis, also meaning it is seen in ischemia and trauma. Here there is air in the bowel wall. Now what I want you to know is you have to sometimes adjust the window in order to see this air. Now, this is commonly seen in ischemia and trauma, meaning you should have a high clinical suspicion. If you get the proper history, you can definitely look for it. But if you don't get, if you see hypodensity in the bowel wall, change the window and come across this particular finding. Look at this case where we can see that there is air within the bowel wall. Now, if you are unable to see it in that window, change the window to lung window. Here, you can see that there is air in bowel wall. Usually, this air is intraluminal. The one that I have represented here with green is usually intraluminal. And this is present in the non-dependent portion. However, if you see air in the dependent portion, meaning like this, which is represented here by the arrows, this is interbowel or intramural air. This is very important. This is a sign of pneumatosis and is a medical emergency, as you all know. Now, after finishing the 5 patterns of enhancement, let us move straight ahead to our main topic, that is inflammatory bowel disease. The way we shall be studying inflammatory bowel disease is we shall divide it into Crohn's disease and ulcerative colitis, see their particular imaging findings and study images there and then. So there are 2 types of inflammatory bowel disease grossly. Now new types have been added. So there are Crohn's disease and there is ulcerative colitis. Coming to the distribution, Crohn's disease, as you all know, is uniformly distributed and with presence of skip lesions, meaning there is normal bowel in between 2 affected bowel segments. Whereas ulcerative colitis is contiguous. There is no normal bowel in between 2 affected segments. Rectum is oftenly not involved in Crohn's disease, whereas anal canal is very much involved in Crohn's. In ulcerative colitis, rectum is very frequently involved, whereas anal canal is not so frequently involved. Let us see some examples. You can see here in this image that there are 2 segments of bowel wall thickening with enhancement. This enhancement is wide type of enhancement, meaning there is active stage of the disease, and there is normal bowel, which I have shown here, in between these 2 segments. So this is a classic case of Crohn's disease with skip lesions in the bowel. Let's see a case of ulcerative colitis. We can see here that the sigmoid colon and the rectum are involved in a contiguous fashion and there is no normal bowel in between affected segments. You can also see that there is mesenteric hypervascularity affecting these particular bowel segments. Coming to the next image, again a case of ulcerative colitis, you can see that the entire sigmoid colon is affected in a contiguous fashion. You can see very prominent vasa recta supplying these sigmoid colon segment that is enlarged, and this prominent vasa recta is also known as Coombs sign. Now this is also a sign that tells us that this is the active stage of the disease. Coombs sign is seen in both ulcerative colitis as well as Crohn's disease. Now, coming next to the differences, ileocecal valve is usually stenosed in Crohn's disease, whereas in ulcerative colitis, it is very less frequently involved. The terminal ileum is very much involved in Crohn's disease and it presents with a string sign, whereas in ulcerative colitis, the terminal ileum gets involved only as the form of backwash ileitis, meaning after the cecal involvement, inflammation spreading over to the terminal ileum is backwash ileitis. Then small bowel. Any segment of bowel can be involved in Crohn's disease. It is classically described as Crohn's disease affects any part of the bowel starting from the mouth to the anal canal. Whereas in ulcerative colitis, only terminal ileum of small bowel is involved, that is as backwash ileitis. Let us see some examples. Here you can see in this image that the terminal ileum is involved. It shows Coombs sign. It shows white pattern of enhancement, meaning active stage of the disease, and the ileocecal valve is stenosed. The same in axial, you can see that white pattern of enhancement with skip lesions. This is the ileocecal valve that I am showing here in green, that is stenosed. Also, you can see skip lesions as well as Coombs sign. Coming next to a case of ulcerative colitis, you can see here that the cecum is showing inflammatory changes and the terminal ileum is only involved as a part of backwash ileitis, meaning only after cecal inflammation and the ascending colon inflammation that the ileum is being involved. In this particular case, you can see that the transverse colon and ascending colon were also involved. However, the entire section is not included here. Coming on to the next, fat. Now this is quite important. Usually it occurs in the chronic stage of the disease. In Crohn's disease, mesenteric fat proliferation. Some people also refer to this as fibrofatty proliferation. So mesenteric fat proliferation is common in Crohn's disease, whereas in ulcerative colitis, perirectal fat proliferation is common. Now you can see here that this was a patient of Crohn's disease. We diagnosed him early on. Then later he went for immunomodulator therapy. He was started on azathioprine as well as steroids. He responded very well, and after 2 years he came to us and we performed a CT scan. We saw that the entire mesentery showed fibrofatty proliferation. This is a stage where we say that the patient is in remission, meaning chronic phase of the disease. There is fibrofatty proliferation and this is good sign. Coming to ulcerative colitis, you can see that this is the rectum and I've highlighted in green that the perirectal fat is enlarged. Now, I want you to remember that many researchers consider the presacral fat pad as a sign of ulcerative colitis, meaning the distance between the sacrum and the rectum. This distance, many researchers have measured it and they consider this as an indicator for prognosis of ulcerative colitis. Now, there are various measurements for this presacral fat pad with varying degree of sensitivity and specificity. You can go ahead and read those articles, but you keep in mind that perirectal fat inflammation, fat proliferation or presacral fat pad thickness increase is a sign of ulcerative colitis. Coming next to the lymph nodes. Lymph nodes are usually enlarged in Crohn's disease, whereas in ulcerative colitis, they are rarely involved. Coming to the complications of inflammatory bowel disease, Crohn's disease is a disease of fistula. By fistula, I mean the fistula enteroenteric, enterocutaneous, or enterovesicular. In enteroenteric fistula, patient usually comes with small bowel syndrome having malnourishment. In enterocutaneous fistula, patient usually comes with discharge from the anterior or the lateral abdominal wall. In entrovesicular fistula, patient comes with a very important history, and you must keep this in mind, have a high suspicion of this history. It is known as pneumaturia, meaning the patient is passing air while passing urine. Now this is pneumaturia. Pneumaturia has two differential diagnoses. The first differential diagnosis being Crohn's, the second being a fistula between the sigmoid colon and the vesicle as a complication of sigmoid diverticulosis. Both are very frequently encountered. So if you get the history of pneumaturia, scroll through the images, find out the fistula level and diagnose either as Crohn's or sigmoid diverticulae. Diverticulae elsewhere, such as small bowel, can also cause these complications, but sigmoid diverticulae is very frequently encountered. So let us see some images. You can see here that this is the enlarged ileal loop, meaning bowel wall thickened ileal loop, and this is fistulizing with that of the urinary bladder. So this was that patient that came with pneumaturia. We diagnosed him as Crohn, started him on treatment. Patient was also taken up for surgery. He recovered well. Now this is another case of Crohn's where you can see this bowel segment having fistulized with this bowel segment. This is the fistula. Alright, moving on. Next complication is toxic megacolon. This is a condition where the bowel loses its entire neurological regulatory pathway and simply dilates. This is usually the large colon, more frequently the transverse and the descending colon, and this is a medical emergency because it leads to perforation, meaning any person who is seeing an abdominal x-ray in the ER, if he finds this enlarged toxic megacolon, it must be taken up for OT because it is a high risk for perforation. Now let's see here. This is commonly seen in ulcerative colitis and rarely seen in Crohn's. This was a case of ulcerative colitis which shows grossly dilated transverse as well as splenic flexure. Descending colon was also dilated on CT. You can see here on CT that the transverse colon is grossly dilated. This was a case of ulcerative colitis presenting with toxic megacolon. Moving on to further complications, strictures and abscess. These are very frequently encountered in Crohn's disease and are rarely encountered in ulcerative colitis. You can see here in this image that the terminal ileum is presenting here with bowel wall thickening as well as stricture associated with proximal dilatation of bowel loops. So this person came to us with acute abdomen, meaning abdominal obstruction. When we saw it on the plain films, we ordered a CT. This patient went in for the OR and on histopathology came out to be Crohn's disease. This is another patient. Actually, these are the thickened bowel loops, and the one represented by the white arrow is actually a peripheral enhancing collection. This particular structure is a peripherally enhancing collection, and this was an abscess as a complication of Crohn's disease. Coming on to the next complication, those are pseudopolyps. Now, pseudopolyps are very frequently encountered in ulcerative colitis. You can see here in this image that the descending colon shows this presence of polypoidal structure. This is a pseudopolyp. Now, I want you to remember that pseudopolyps cannot be differentiated from true polyps on imaging alone. I shall tell the significance in just a minute. Sclerosing cholangitis is a complication very frequently encountered in ulcerative colitis, and colorectal carcinoma is another complication that is very frequently encountered in ulcerative colitis. Now, this is very important that whenever you get a patient of UC and you see such a complication, meaning a polyp, you can never tell whether it is a pseudopolyp or patient has progressed to carcinoma of the bowel, usually the large bowel. So you should always give this as a possibility of polyp as well as pseudopolyp. This was a case where we gave the possibility of both polyp and pseudopolyp. My gastroenterology colleague went ahead with the colonoscopy, did a polypectomy, and on histopathology it came out to be a pseudopolyp. However, it could have very well be a carcinoma of the descending colon. So never give a pseudopolyp directly in a case of ulcerative colitis because carcinoma of the large bowel is very frequently encountered in ulcerative colitis. Now, having learned the differences and complication of these two diseases, it is important to inform our gastroenterology colleagues that whether their treatment is working, meaning the patient has come in active stage of the disease after treatment, after 6 months, you performed another scan, and whether the patient has gone in remission or chronic phase of the disease. So, certain signs on CT as well as MR tell us that this is the active stage of the disease and this is the chronic stage of the disease. So we shall study how to predict which stage of the disease Now these are predicting the stages of IBD. There are certain pointers towards active stage, certain pointers towards fibrotic stage or the remission stage or the chronic stage, and certain pointers towards the non-specific stage. Active stage, as I have been already mentioning throughout our discussion, that white pattern of bowel enhancement, water halo sign, Coombs sign. These are signs of active stage of the disease. Mesenteric edema is also a sign of active stage. Now, abnormal motility. We do something known as cine MRI. More on cine MRI I shall be covering in our MR enterography discussion module. You can see that in our channel. Now, abnormal motility is also a sign of Crohn's disease, active stage. Now, complications. These are usually the complications of Crohn's disease. Abscesses, sinuses, fistula. These are all signs of active stage of the disease. Coming to fibrotic or chronic stage, the fat halo sign, late progressive homogeneous bowel wall enhancement, as well as fibrosis, these are signs of fibrotic or the remission phase. Fat proliferation, mesenteric, that is seen in Crohn's disease, and perirectal fat proliferation, that is seen in ulcerative colitis, both of these are signs of fibrotic stage. And pseudodiverticular, this is a complication of fibrosis, meaning if the mesenteric border is affected by edema and on remission, it goes into fibrosis, meaning it contracts. So the mesenteric segment of the bowel, it also contracts, and the anti-mesenteric border shows this pseudo-diverticulae, also known as pseudosaculations. I shall draw a representative diagram here. This is the normal bowel and this is the mesentery. If this segment is affected and goes for contraction, how will it present? This is the contracted mesenteric segment. This has gone for contraction, and the anti-mesenteric segment will show like this. These are the pseudosaculations or the pseudodiverticulae. Coming next to the non-specific findings, this is bowel wall thickening, skip lesions, and lymphadenopathy. These can either be seen in active or in the chronic stage or the remission stage. Now, having predicted whether the patient is in active or in remission phase, it is also important that a first time patient, if he comes to you, you diagnose Crohn's disease or inflammatory bowel disease. Many a times in our country, Crohn's disease is very frequently masqueraded by abdominal tuberculosis. Now, these two are very close differential diagnosis and you need to differentiate them because the treatment is completely different. In Crohn's disease, you start with immunomodulators or steroids, whereas in abdominal TB, you start with antituberculous treatment. You mix them and the patient goes for havoc. A detailed module of abdominal tuberculosis I have already covered, and the link of the description you can find here below. Now, abdominal tuberculosis I have covered in that module, meaning gastrointestinal, lymphadenopathy, the peritoneal manifestations, whereas in this particular class, we shall only see the important differences between inflammatory bowel disease, that is Crohn's disease, and abdominal tuberculosis. I'm sure most of you already know this, but this is just for the sake of revision. Length of bowel involvement in Crohn's disease is usually long segment, whereas in TB, it is short. The multiple site involvement, that is skip lesion, is a frequently encountered thing in Crohn's, whereas in TB, it is less frequently encountered. Type of bowel wall enhancement, here it is stratified, meaning the water halo, fat halo comes into play, whereas in abdominal TB, it is quite homogeneous. Complications such as perianal fistula, mesenteric abscess, bowel fistula, also known as other types of fistulas can also be present, such as entrovesicular fistula. These are quite common in Crohn's disease, whereas rarely seen in abdominal tuberculosis. Strictures are seen in both. Bowel obstruction can be seen in both, whereas the strictures in Crohn's are eccentric along with saculations, also known as pseudosaculations. Whereas in abdominal tuberculosis, the strictures are concentric. Increased vascular mesenteric vascularity, that is also known as the Coombs sign, is a feature of Crohn's disease which is not seen in abdominal tuberculosis. Fibrofatty proliferation, that is ulcerative colitis or Crohn's disease going into remission and showing extensive fibrofatty proliferation in the mesentery or in the perirectal region respectively. This is a feature of Crohn's disease, whereas not seen in abdominal tuberculosis. Mesenteric lymph nodes. Now, lymph nodes are seen in both Crohn's as well as abdominal TB. These are small and homogeneous. in case of Crohn's, whereas large and necrotic with conglomeration present in TB. Now, very good diagrams I have covered in the abdominal TB module, the link of which you can find in the description below. Do check out that particular module because that also is a very, very important topic. Omental caking is very frequently encountered in abdominal tuberculosis, and solid organ involvement is rarely seen in Crohn's, whereas very, very frequently in abdominal TB. Now, having completed these differences, we come to end of this module on inflammatory bowel disease and bowel wall enhancement. If you have liked our conceptual way of teaching difficult topics, put a like in the video. Comment on any other further topic if you want us to take, you are finding it quite difficult, and do subscribe to our channel.
Hey guys!
If you like our simplified approach to difficult conceptual topics,
Please do comment, like, share, and subscribe to our channel.